Good morning, everyone. I hope you're all doing well today. Let's start our session on infectious diseases of the cardiovascular system chapter. We'll start with brief review of heart anatomy. We'll understand different modes of infection of the cardiovascular system. Major diseases include infective endocarditis, myocarditis, pericarditis, and rheumatic heart disease. We'll discuss diagnosis and finish with prevention methods. Today, we're going to discuss a topic that beautifully connects microbiology with your field, cardiotechnology, and that is infectious diseases of the cardiovascular system. Now, when you hear cardiovascular system, what comes to your mind? The heart, the blood, and the blood vessels, right? You've studied its anatomy and physiology in detail. But today, I want you to look at it from a microbiologist's perspective as a system that is usually sterile, but when invaded by microorganisms, can become the site of some of the most dangerous infections in medicine. Remember this, the cardiovascular system is normally sterile. Under healthy conditions, you should not find a single microorganism, no bacteria, no fungi, not even viruses, circulating in the blood. So whenever we detect microorganisms in the bloodstream or on the heart valves, it indicates something is very wrong. And that's the core of today's discussion. Let's first recall the structure of the heart because this will help us understand where infections can take place. The heart has three major layers. The endocardium lines the inner surface of the heart chambers and the valves. When this layer becomes infected, we call it endocarditis. Then comes the myocardium, the muscular layer that contracts to pump blood. When that muscle becomes inflamed, the condition is myocarditis. And finally, the pericardium, the outer protective sac that encloses the heart. Inflammation of this membrane leads to pericarditis. So you see, depending on which layer is involved, we use different terms. Keep that in mind as we move forward. The cardiovascular system functions as a closed circuit, delivering oxygen and nutrients to tissues and removing waste. Because it's closed, it's naturally protected from infection. However, once microorganisms find a way in, they can spread rapidly because the bloodstream is like an express highway. One organism entering here can reach the entire body within seconds. So how do these microbes enter the bloodstream or the heart? There are several routes of infection and it's important you understand each one. First, the most common route, hematogenous spread. Microbes can enter the bloodstream from another site of infection. Let's say someone has a dental abscess or a urinary tract infection. Bacteria can enter the blood and travel to the heart. That's why patients with heart valve abnormalities are advised to take antibiotics before certain dental procedures because even simple tooth extraction can seed bacteria into the blood. Second, direct extension. Infection can spread from nearby infected tissues. For example, if there's an infection in the mediastinum or the lungs, it can extend to the pericardium. Third, medical procedures, any invasive procedure, cardiac catheterization, pacemaker insertion, valve replacement carries a risk of introducing organisms, especially if aseptic precautions are not strictly followed. And finally, vector-borne transmission. Some pathogens, such as Trypanosoma cruzi in Chagas disease or Rickettsia in typhus, enter through insect bites and later involve the cardiovascular system. Once microorganisms get into the bloodstream, they can cause a range of problems from transient bacteremia to life-threatening septicemia or even infective endocarditis. Bacteremia just means the presence of bacteria in the bloodstream. It might be transient, like after toothbrushing or minor injury. It can be intermittent, such as in patients with abscesses, or continuous, which happens in infective endocarditis when bacteria keep shedding into the blood. Common organisms include Staphylococcus aureus, Streptococcus pyogenes, E. coli, Pseudomonas aeruginosa, and Neisseria meningitidis. Now, When this bacterial presence becomes persistent and triggers an inflammatory reaction in the whole body with fever, low blood pressure, and organ dysfunction, we call it septicemia or simply sepsis. Sepsis is one of the major causes of death in intensive care units worldwide. It's not only the bacteria, but their toxins that cause severe endothelial damage, activation of inflammatory cytokines, disseminated intravascular coagulation, and multi-organ failure, what we know as septic shock. Clinically, patients present with high fever, chills, tachycardia, low blood pressure, and sometimes a petechial rash, especially in meningococcal sepsis. If not treated rapidly, this condition can be fatal. The gold standard for diagnosis is blood culture, always taken before antibiotics are started. We also use gram staining, biochemical tests, and increasingly molecular methods like PCR for rapid detection. Serological markers such as procalcitonin and C-reactive protein help monitor severity. Treatment involves broad-spectrum intravenous antibiotics given immediately, later adjusted according to culture results. Supportive therapy, IV fluids, oxygen, and vasopressors is crucial to maintain organ perfusion. And the prevention, very simple, maintain aseptic technique during invasive procedures and treat local infections early before they spill into the bloodstream. Next, infective endocarditis, a microbial infection of the endocardial surface, particularly the heart valves. It can affect normal valves, but more commonly it targets damaged or prosthetic valves. In native valves, the most common organisms are Streptococcus viridans, Staphylococcus aureus, and Enterococcus faecalis. In prosthetic valve endocarditis, Staphylococcus epidermidis is often the culprit. In drug users, we frequently find Pseudomonas aeruginosa or Candida species. Endocarditis starts with a small injury on the endocardial surface, leading to platelet and fibrin deposition. When bacteria adhere to this site, they form vegetations, masses of platelets, fibrin, and microbes. These vegetations can erode the valve tissue or break off and travel as emboli to other organs, brain, kidney, or spleen. Clinically, patients often come with fever, malaise, fatigue, and weight loss. You may hear a new or changing heart murmur on auscultation. There can be petechiae on the skin, Osler's nodes, tender nodules on the fingers, Janeway lesions, painless spots on the palms or soles, and Roth's spots in the retina. Some patients even develop splenomegaly due to immune stimulation. Diagnosis involves at least 3 blood cultures before starting antibiotics, plus echocardiography to detect vegetations. Diagnosis is based on the modified Duke criteria, which combines clinical, microbiological, and imaging findings. Treatment involves prolonged intravenous antibiotics, usually for 4 to 6 weeks. Sometimes, if the infection is not controlled or the valve is destroyed, surgical valve replacement is needed. Prevention: high-risk patients, especially those with prosthetic valves or previous endocarditis, must receive antibiotic prophylaxis before dental or surgical procedures. Now, let's talk about myocarditis, inflammation of the heart muscle. Viral causes include Coxsackie B, adenovirus, and parvovirus B19. Bacterial causes include Corynebacterium diphtheriae, and protozoal causes include Trypanosoma cruzi in Chagas disease. Viruses infect cardiac muscle cells, and the body's immune system continues to attack them, causing myocardial damage and reduced contractility. Symptoms include chest pain, palpitations, fatigue, and shortness of breath. Severe cases can lead to heart failure or arrhythmias. Diagnosis: elevated cardiac enzymes like troponin, ECG changes, echocardiography showing reduced ejection fraction, and biopsy confirming inflammation. Treatment is supportive, rest, oxygen, heart failure management, and sometimes antivirals or immunosuppressants. Pericarditis involves inflammation of the pericardial sac. Viral causes include Coxsackie virus and echovirus. Bacterial causes include Staphylococcus aureus, Streptococcus pneumonia, and Mycobacterium tuberculosis. Pain is sharp and radiates to the shoulder, worsening with inspiration. On auscultation, a friction rub is heard. In severe cases, fluid accumulates, causing pericardial effusion or cardiac tamponade. Diagnosis: ECG shows diffuse ST elevation. Echocardiography detects fluid and pericardial fluid analysis confirms the cause. Treatment: NSAIDs for pain, antibiotics or anti-TB therapy as needed, and pericardiocentesis for tamponade. Rheumatic fever is a post-streptococcal autoimmune reaction. It follows throat infection with Streptococcus pyogenes. Antibodies cross-react with heart tissue, leading to inflammation of valves, myocardium, and pericardium. Major Jones criteria include carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Long-term consequence: mitral stenosis and chronic rheumatic heart disease. Diagnosis: elevated ASO titer and echocardiography. Treatment: penicillin and anti-inflammatory drugs. Prevention: early treatment of streptococcal infections. Protozoal and rickettsial infections such as Chagas disease, Trypanosoma cruzi, and typhus rickettsia can also affect the heart by causing myocarditis and vasculitis. Laboratory diagnosis of cardiovascular infections relies on blood cultures, gram staining, biochemical identification (PCR), serology, CRP, procalcitonin ASO titer, and imaging like echocardiography or CT. Finally, prevention and control: maintain aseptic techniques, use prophylactic antibiotics in high-risk patients, treat streptococcal infections early, sterilize instruments, and control vectors. As future cardiotechnologists, infection control is one of your strongest defenses. To summarize, the cardiovascular system is sterile but vulnerable when breached. Major diseases include bacteremia, septicemia, infective endocarditis, myocarditis, pericarditis, rheumatic fever, and rare parasitic infections. Early diagnosis, appropriate therapy, and strict infection prevention are essential. That concludes today's lecture on infectious diseases of the cardiovascular system. Please follow #Modern Microbiology Academy for more such lectures.